sponsored by the Office of Family Life of the Diocese of Arlington and our own Respect Life Committee here at St. Charles Parish. First, a couple of housekeeping points. You will find our Respect Life volunteers in the blue polos. So when you see the folks in the blue polos, the kind of royal blue polos, maybe thank them, or if you have any questions or you need to find something, you need help with something, just ask them, please. When it comes time for the Q&A for our panelists, there will be a microphone available. So wait till you get the microphone to speak, please. And there are bathrooms right in the back of the gym. So there are larger bathrooms downstairs, but there are also bathrooms available right here in the back, which makes it easy. I'm going to sort of be bilocating today. I have Spanish baptisms in 5 minutes, so I'm going to introduce our first speaker, and then I'm going to head down to the church and do the baptism thing, which is a great thing, you know, and then I'll be back up for the rest of the conference. So I begin by introducing Dr. John Bruchalski. I first met Dr. John Bruchalski 21 years ago. I was assigned as a deacon to St. Joseph's Parish in Herndon in 1992, the summer of '92. Is that still your parish? It still is, great. So we met in 1992, and he was a young, or we all young, struggling doctor. He had just finished his OB residency in, was it Hampton or Norfolk? Norfolk. He'll tell you a little about his own biography. And it was just a couple years after that that he founded the Tepeyac Family Clinic. And then later on, it transformed into Divine Mercy Care. He'll be telling you about all of the good work that he's done. I'm going to embarrass him now and tell him that although we don't see each other regularly, we see each other from time to time and things like this over the years. In my different, whether it's when I was pastor at Holy Family in Dale City, when I was at Christendom College as chaplain the last 4 years, never have I sent anyone to Divine Mercy Care, to Tepeyac Clinic, who was ever refused anything. I dealt with young women dealing with crisis pregnancies, with fertility problems, with all number of issues. And I would send them to Tepeyac Clinic, and even if they had no health insurance, had no way to pay for services, they were always received with mercy, with love, with open arms, and given everything they need. And many times they've come back to me and said, thank you for referring me there. So the work that they do is great, oftentimes without remuneration, without recognition, but we're happy to recognize Dr. John Bruchalski today and his work at the Divine Mercy Clinic. Come on up, please.
It is wonderful to be here today with you all. It's exciting to be in a parish that has their Wednesday night 3 Ps. Prayer, penance, and the pub for their young people in the audience. I came that they might have life and have it more abundantly is on their parish bulletin. This idea of abundant life. I'm a 53-year-old married man to Carolyn, the love of my life, who I met in Norfolk while I was at the Jones Institute for Reproductive Medicine. And it was there that I had my conversion, or my change of heart, as I like to put it, about this issue. So I do want to thank I just want to thank you all for this invitation. I'm a clinician. I'm not an academician. I see patients every day in our practice who suffer the challenges of living in this world today, the challenges of relationships, the challenge of fertility, the challenges of infertility. And so I just want you to know that whatever we speak about today, there's no judgment on my end. 1 in 2 families have ended up in divorce. 1 in 3 women have had an abortion. 1 in 4 women have had a sexually transmitted disease. 1 in 8 women are infertile. And 8 out of 10 women have used some form of contraception in the past. And so I go forward just opening up here that the topics that we talk about today, or that I'm going to be talking about, are challenging for many of us. The title of my talk today was Brave New World, I Make All Things New. From Welcome to Wanted, the practical fallout of a consumer approach to reproductive health. That's kind of the emphasis of what I want to talk about today, is how when you begin to changed the definition of what is a human person, many untoward consequences followed. And like I said, there are many, many good doctors in the area here who are reproductive endocrinologists who do in vitro fertilization, who I have deep respect for. I may disagree with some things, but like I said, those folks who have suffered infertility, our faith is incredibly aware and sensitive to that pain. I picked it because it's the 1931 novel of Aldous Huxley. It's all about controlled reproduction and guaranteed perfection, this idea of the designer baby as we see today. It also had the Bruchalski process, which was this whole idea that the alpha and betas of society, the well-to-do, got a single perfect child, and the lower castes in society had just been given cloned embryos for their children. And once again, all these embryos and fetuses, all these babies were bathed in chemicals that made them perfect, made them healthy, made them without disease. And so, once again, this title was provocative for me, especially during my change of heart. Now, we've come a long way in reproductive health. Our Planned Parenthood fiscal 2014 report said, we've come a long way since Margaret Sanger was jailed in 1916 for opening America's first birth control clinic. Planned Parenthood did over 327,000 abortions last year, up 450, almost 500 from the year before. But also, as this parish reminds us on Father Serby's website, nowadays it's not enough for men and women to be good. Moreover, it's not good enough to be satisfied with being nearly good. It is necessary to be revolutionary. And what I want to talk about for about the next 30 or 40 minutes is this idea of revolutionary and how it applies in my particular practice of OB/GYN, of taking care of women. We're at the end of the Christmas season, right? We've just celebrated 3 weeks of Christmas, and it's been filled with many challenging concepts that I face and we face in our daily families and practices. Crisis pregnancies, out-of-wedlock births, infertility, older moms, no room for them at the inn, that connection between social justice and the gospel of life. The story also includes the original IUD, the intrauterine device, the camels that brought the wise men to Bethlehem in order to prevent fertility. Rocks were placed inside their uteruses on those long journeys. Also, the question is of wise men and an epiphany. What do we need today to have an epiphany on this topic of bioethics? What does it take for us to really realize the humanity of the human person, of the embryo? And so this idea of wise, what does it mean for myself to be a wise man today, or a wise woman in your cases? What does it mean for that? On Monday, I had a chance to speak at the cathedral, and it was the Thomas More Cathedral, right? This is where he said, I am the king's servant, but God's servant first. That's the concept. That's where we begin to move. It's also this idea, how do we speak to a new generation? I see a lot of young people here today, a lot of nursing students, it's incredible what you've done here at this parish. Do any of you all know about Mumford & Sons? Yeah, it's great. When the Holy Father talks about a new approach, this kind of new idea of how to get inside people's hearts, how fickle my heart and how woozy my eyes, I struggle to find any truth in your lies. And now my heart stumbles on things I don't know. My weakness I feel I must finally show. In these bodies we will live, in these bodies we will die. Where you invest your love, you invest your life. Awake my soul, for you were made to meet your maker. This tune. I mean, I'm walking through my office someday, and that tune just gets stuck there, gets stuck here. So once again, I'm a clinician, and words matter. how many of us, no show of hands please, but how many of us were told that we had a blighted ovum when we miscarried? Blighted ovum. Ovum means egg. Blighted means it's no longer viable. It's failed. Well, that blighted ovum was your child, was a miscarriage. But in our attempt of mercy to try to lessen the pain, we try to numb the truth or change the truth. We're going to talk about that. And lastly, it's the season of the Epiphany, which was last week. And James Joyce used to talk about the Epiphany. In every one of his stories, there was an epiphany moment for the characters, for the protagonists. It's an experience of a sudden and striking realization. Generally, the term is used to describe a scientific breakthrough, religious or philosophical discoveries, but it can apply in any situation in which an enlightening realization allows a problem or situation to be understood from a new and deeper, and I would add, sacrificially loving perspective. That's my prayer. That's the prayer of this parish. They have John 10:10 on the front of their bulletin. I want to have life and have it abundantly. We want to walk with Christ closer. And so that's my prayer for this talk today. This idea of this chronology. As reproductive health has changed, the church has kept up trying to help us, because when you add the passion and the desire of childbearing or not having children, if you add that to technology and the scientific drive, you end up in places where there is very little moral guidance. And so the church has been very helpful. Sister will be talking about the theological and philosophical ramifications or the underpinnings of what we believe as Catholics. Because what happens is that we actually kind of live in fear. The fear of another pregnancy, the fear of never having children, the fear of getting old, the fear of death, the fear of not paying our bills, the fear of losing our beauty, the fear of losing our mind, the fear of losing our nation, the fear of performance in bed, the fear of losing status, the fear of our employer finding out how depressed we are, fear of commitment, fear of losing our partners, fear of being judged, fear of failure, fear of what others think about us, fear of not living up to the charade we have created about ourselves. These are simple things I pulled out of my practice over the last month. I call it kind of the new yellow fever epidemic. We're constantly trying to move folks. When we talk about transforming hearts at Tepeyac Family Center and Divine Mercy Care, how do we move from fear to trust? How do we move from welcomed to wanted? We're going to talk about this here. And yet, in the end, it's all about the fear of God, right? Is the beginning of wisdom, as Psalm 111 quotes. Romans 8:15, for you did not receive the spirit of slavery to fall back into fear, but you have received the spirit of adoption as sons, by whom we cry, Abba, Father. Trying to move people from fear to trust. How many times does that control and influence our lives? So once again, the basics of this talk are a key question. I'm going to give you some examples of the challenge of reproductive consumerism, and then I want to talk a little bit about the Tepeyac Family Center and the hope that you can bring by, rather than repressing fertility, cooperating with it, okay? So we're going to begin with this story. Jane and Jim come into the practice, and they are about 33 years of age, and they have been trying to have a baby for the last 3 years. They've tried a few things naturally, but it hasn't worked, and now they've come to the center, and they've been with us, say, now a year, and we have tried cooperative medicine with them, and for whatever reason, it hasn't worked. They're moving on. They're now asking the question, should we go on to IVF? Or give me a referral to the IVF center. And so what I found practically in our practice that works fairly well is you begin to talk and you say, listen, what happens in IVF is that they're going to give you drugs to help you create eggs. They're going to recruit several eggs through surgery. And then they're going to take your eggs and mix them with your husband's sperm in the laboratory. And now this is the question. They're going to make several embryos in this approach. You and your husband, because I'm usually talking to the woman in my practice as a gynecologist, you and your husband have to answer one question before you go there. And that is, are the embryos that they're going to make, are they your children or are they your property? Because you need to think about that some before you go. Because so many patients that I have seen, that question comes up after the fact, when they already have frozen embryos, when they already have wasted 10 embryos to get their one child. So the question that you must ask is, are those embryos that they're going to make your children or your property? Do you love them or do you own them? That's the question. And oftentimes I don't give an answer to that because they're trying to process this. We live in a world today, in a day and age where words don't have the same meaning. When we say divine mercy care, we're talking about compassion, walking with, suffering with. When a woman has a miscarriage, we will walk with you through this process. If you have an unexpected pregnancy, we will walk with you through that process. Mercy is not mercy killing, to end suffering. It's to help relieve suffering and continue to walk through that process with that patient. And so this idea of, are the embryos that the doctor is going to make, are they your children or are they your property? That's the question that has opened the door up to so many of our patients going, you know what? I think I begin to understand that challenge, that fear, that feeling of difficulty. So now we're going to go ahead and talk about some practical examples of the consumerism found in reproductive health. And this is another story. So I trained at the Jones Institute for Reproductive Medicine. I'm a 53-year-old man. I have 2 boys who are still single. They're 19 and 22. So for any women in the audience who are still single, they both go to VMI. It's a plug. There's no doubt about it. I'm sure they would be embarrassed if they knew I said that. And I apologize, JP and Joe. But I'm a clinician. I'm a parent. I'm a family. I'm a dad. I'm a husband. And so I grew up in a great family, a great Catholic family. We prayed for the conversion of Russia every day as a good Polish family. And in my lifetime, I saw the wall fall down. We also prayed for ourselves, that we would have a change of heart. Because once again, my dad taught us that, just like Lenin said, that if he would have met someone with the zeal of St. Paul, he never would have become communist. It's up to us in this room, folks. I was talking to Sister Claire about a new approach to what she's doing, constantly thinking outside the box. What can we do as a people to take the truth of Jesus Christ and of our faith and transmit it to our friends, to ourselves? So here I am, growing up in a good Catholic family. I went to good Catholic high schools and Jesuit College of Salesian High School. And in the end, I was somewhat confused and somewhat, a typical young man growing up trying to find his way. I decided to become a physician because my older cousin, he became a physician. My daddy was a school teacher. So I kind of just let it all slide away. And I fully believed that as a doctor, as a gynecologist, I wanted to liberate women from the chains of their fertility. That was the goal, because if we could control our fertility, we could then live a happier life. So I went to medical school, and an abortionist said, Johnny, you have a great insight into our patients. You really love taking care of PMS. You're good at treating it. You're good at it as a surgeon. Have you ever thought about being a gynecologist? where you could push help women have healthier lives. And so it was there that I decided to provide all reproductive care, abortion, contraception, and I went to the Jones Institute for Reproductive Medicine in Norfolk, Virginia. That's the home of the first in vitro child in this country. It was there, thanks to the prayer of my mom and dad, I'm sure, the constant prayer, right? What was that first line from Scripture this morning, from 1 John 5? If you pray what is his will, it will be given to you. Well, I had one of those Damascus moments in the middle of my residency. I went to Guadalupe with a friend of mine for a secular reason the year before in 1987. I heard something at the Basilica about, why are you hurting me? I quickly ran away from it. And in the middle of my residency, I had a change of heart on this issue. Needless to say, while I was there, it goes to this first question. We used to sit on our reproductive elective, we used to sit at the round table with the Joneses, Howard and Georgiana Jones. They left Johns Hopkins at the age of 65. They came to Norfolk, where they created a team to do the first in vitro fertilization in this country. And they were successful. But every Tuesday and Thursday, we would sit around this table and debate progesterone levels on an egg maturity. Well, while we were there, I looked, one of my professors who I really liked took me into the library, and she wanted to show me some of the funny things that were found in our textbooks, some of the quirks of the profession, so to speak. Well, what happens is in 1973, Williams' textbook of OBGYN, that's kind of the Bible for us at the time, in the back, she showed me where they changed the definition of personhood, of human life. Up until Roe v. Wade, it was life begins when, folks? At conception. Well, not true. Not true anymore, maybe I should say. Fertilization became implantation. It was changed without any discussion with the American College of OBGYN. It was a political change to the definition of when human life should be respected. Why was that? Because the sister will tell you, as you separate love and life, then you separate life from marriage, and then you can have sex without babies and then babies without. Fascinating. So she showed me this, and it's the first. So it was a political change. And I learned very early on that science is not neutral. Science is a tool to be used by folks. When you talk about drawing up data, it's ideologically driven much of the time, some of the time, much of the time. Just think about breast cancer and abortion. That's a whole other discussion. But it was also there at the Jones Institute, before my conversion, that our professor, Howard Jones, was discussing the nature of the embryo, he called it the pre-embryo, with Dr. Jerome Lejeune in Tennessee at a court case. Talk about schizophrenia on my end. So I was there buying into everything. We were a contraceptive research and development center, so we were putting in IUDs right after birth so these young poor girls would not get pregnant before they came back to see us. Somewhat like an animal. We talked about it. But our intentions were good, to not let them get pregnant, which would, if they don't get pregnant, they can get out of their poverty. Once again, this is what we wanted to do. And yet Howard Jones coined the word pre-embryo. Why? Because by the time from 1973 to 1987 or 88, we now had to create a new word to distance people from the reality that embryos are really your children, but they're very young. They are your children with full of potential, not potential children. That's the other thing that really bugged me. Johnny, get over it, man. They're not human. They're not your kids. They're potential kids. But Dr. Jones, why do we have more psychiatrists now? We used to only have one. We used to cycle 400 women every quarter of a year, every 3 months, 200, 400 women, because we were the only center in the country at the time, or one of the few. One psychiatrist when I started, 4 psychiatrists when we finished. Why were women having a hard time with something that really wasn't their child? Because this was right at the time we began to learn how to freeze embryos. We're going to talk about that in a minute here. The next question is, life is now not relevant to the debate in OBGYN. Life is not relevant. How do I know this? Because Cecile Richards of Planned Parenthood told us in February of last year. It's not something that I feel is really a part of this conversation. I don't know if it's really relevant to any conversation. Jose Ramos in the program Fusion asked her, when does she think that life begins? And he kept pressing her because she's the mother of 3, a mom. Well, life was started when they delivered, she said. She finally said. But her quote is, we don't have to answer a question that will be debated through the centuries, but provide options. All we're doing is providing options for pregnant women. It's this consumeristic approach of wantedness. If the child is wanted, it's okay. If the child's not wanted, then you can do with it what you will. Another story to tell you. I'm at a medical school at the University of Virginia 2 or 3 years ago. And I give this presentation on abortion. If it's so good, why don't more doctors do it? And a young man comes up at the end. He goes, I'm a third-year resident, and do you really believe that life begins at fertilization? I said, yeah, I really do. It makes sense genetically. It makes sense practically. We've moved from a scientific definition of when life begins, 46 chromosomes, it's not a monkey, it's not an oak tree. But now the definition is sentient. When does the child have awareness? That's not a scientific principle, but that's what we're operating on now. Doctors are becoming they're becoming the physicians of desires. You want a child, you don't want a child. And this is how I felt. You want a child, you don't want a child, I'm a technician, I can help you. Physician, healer, divine physician, technician, leave your conscience when you enter the door of your clinic. Just give the woman what she wants. Patient autonomy is paramount. I want you to understand that in most medical schools, they don't even have this conversation. It begins at a later date than fertilization. That's a given. That door has been opened and the cow is out of the barn, so to speak. Well, why does that matter? Because this is the other point I wanted to talk about briefly. This is the Journal of Medical Ethics. This is, the title of the article was, After Birth Abortion, Why Should the Baby Live? Once again, if both the fetus and the newborn do not have the same moral status as actual persons, fetus and the newborn does not equal a person yet. And the fact that both are potential persons is morally irrelevant. Adoption is not always the best interest of the actual person, so the authors argue that what we call after-birth abortion, killing the newborn, should be permissible in all the cases where abortion is, wanted or unwanted, including cases when the newborn is not disabled, including when the newborn is not disabled. This article was written in 2012. It's now beginning to filter into our college campuses, that it's perfectly okay to kill the newborn if it doesn't pass certain tests. Talk about the commercialization of the human person. If it doesn't meet a certain standard, why? Because those 2 Italians who were living in Australia who wrote that article, they looked at all the European databases, and they found that there were 17,000 Down syndrome children being born every year. Why was that? If we can identify them in utero, why would they be born? As my cousin Michael, who has Down syndrome, said, Johnny, am I an endangered species? Down syndrome. We're talking about Down syndrome, because 60% in Europe, they can figure out ahead of time that it's affected, and so therefore you can take care of it. Right? Remember I talk about these words that keep popping up in reproductive care? Take care of it. Think about the different ramifications of what that means. What about sacrifice? The sacrifice of all those unborn, of all those people in early Mexico to the gods to please. Sacrifice versus sacrifice. Mercy versus mercy. The words, we're going to talk about that in a minute. This is where we're at. Because as Pope Francis keeps talking about, if you don't defend the unborn, then everything else kind of begins to fall apart. Whether it's the perversions, whether it's not taking care of them socially with social justice. Once this conviction disappears, so do solid and lasting foundations for the defense of human rights, which would always be subject to the passing whims of the powers that be. Next problem, abortion is prevention. I just talked about the Down syndrome case, the little munchkin on the left. The pills on the right are the morning after pill. What happens is we're beginning this slippery slope in reproductive care. This is how the morning after pill works. But what I'm telling you is that we now take contraception, and it works, in the real world, it works 96% of the time. It has a 4% failure rate, oral contraceptives. Well, wait a second. If you miss taking the pill, but you want to not get pregnant afterwards up to 3 to 5 days, we can give you more hormones to take care of that problem. And now you're beginning to use contraception as wait a second. The pill, the morning after pill, works the same way by trying to inhibit ovulation, trying to stop or delay ovulation if you take it before time. It's why if you start a hormone in the middle of your cycle gets screwed up. Bleeding happens irregularly. It thickens the cervical mucus, or tries, but if there's a conception already, the high-dose progestin will thin the lining of the uterus. But remember, it only happens in those cases but don't worry about it, because life didn't begin already. Pregnancy hasn't begun. The blastocyst is in the tube. It's not really implanted yet. It's not a pregnancy. What's the big deal? Just take the morning after pill, prevent the pregnancy. Then what happens is we now just like everything else in reproductive health, we start off with these high doses, whether it was the high dose pill in the 1970s, we're now at a low dose pill with a higher escape ovulation rate. Also with the morning after pill, you had to take 2 tablets at first. Now you can only take 1, you should only take 1 because of the side effects. Things are changing. We now have medication that goes after progesterone, which is RU486 or mifepristone. Something else that just came up recently is the Indian sterilization camps. In the Wall Street Journal in the middle of December, there was this article, Death Exposed Ills of India's Healthcare. Undergo assembly line operations. Healthcare is becoming polarized in India, was the comment. Government-run camps are used to provide cut-rate surgery. 13 women died in one facility in central India. It shined a harsh light on the multiple failings of the chronically underfunded public health system. Them being treated as cattle, like veterinary medicine, they said, as if they were sheep and cows. Many lay on sheets on the floor. Floors were covered in rat feces. Toxins were found in the antibiotics. Severe infections were cropping up because of poorly sterilized surgical instruments. When I heard it, it reminded me of the Gosnell Clinic in Philadelphia that happened in this country. That so much was not reported in the public, in the press. And then we get to the baby chase, designer children. There's a book out now called The Baby Chase. It's about a husband, Rhonda and Jerry, a husband and wife. She was abandoned with her first marriage, and then she was deceived in her second when her husband didn't tell her about his vasectomy. He had it reversed. She had 2 uteruses, and it was so expensive to have a surrogate here in this country, they decided to go to India and spend $5,000 on a surrogate through donor eggs and Jerry's sperm, and they got a healthy boy. Well, a few years later, the same person said, I can give you more eggs because I would love your son to have a sibling. And so triplets were conceived, delivering 2 a few years later. And this book is about the controversial support of surrogacy. It was written by Leslie Steiner, and it's about, even though it's a controversial topic, this is the way families are being conceived today. It's a reality. Many of us here have been touched or affected with the branching out from the genetic parent, mother and father through donor eggs, donor uteruses, anonymous sperm donors. What was challenging in our practice was that I still remember when I was in Norfolk, a young patient came in. When I was in Norfolk, we took care of these patients. Well, I saw this patient that I might have been a part of her conception. She came to see me in Fairfax, where we work now. And she may have been conceived on one of the cycles that I was on in Norfolk at the time. She wanted to know who her father was. She found out that she was a sperm donation child, and she wanted to know what the genetics was. Well, at the time, it was illegal to pursue that. She could not find the genetics of her biological father. And that challenge, that sadness is occurring more and more and more today in our patient populations. So the next issue is going to be the in vitro fertilization or artificial reproductive technology. It came out of the 1930s with the artificial insemination of cattle. It's where we take drugs to superovulate a woman to make multiple eggs. And over the course of time, we will, between days 3 and 5 of a normal cycle, we try to recruit 4 to 6 eggs. However, it can get much more. We then remove those eggs through a surgical procedure. We check their maturity and morphology. Are they normal? Then we mix it with about 50,000 sperm outside in the laboratory and we check embryos, day 1, day 2, day 3, day 4. As these embryos grow, we begin to put the healthy ones back in the uterus. 2 to 4 are implanted. And that's usually anywhere from 48 to 90 hours after a retrieval. 10% of the time, at least, you get twins or triplets. And then we're going to talk a little bit about selective reduction. Because once you remove the definition of life, then it's just a matter of efficacy and efficiency and statistics. Because there's a higher risk with twins, multiples, twins, and triplets, we are beginning to reduce those triplets into twins or into singletons, meaning we abort one of your triplets. This is what I talk about the schizophrenia or the difficulties here. Abortion is prevention. Once you say that life begins whenever you decide it does, then you get rid of diseases by getting rid of the person with the disease, whether it's an embryo or a child with Down syndrome or a child with a trisomy. The live birth rate per cycle is between 10 and 40%. We're becoming better at it. In vitro fertilization, we were realizing that there were many side effects early on. And so now we have patient-friendly natural cycle IVF, which we can talk about at a later time. The cost is anywhere from $10,000 to $60,000 per cycle. 65% of embryos implanted do not result in a live birth. And yet, millions of families have been started, millions of women have been given children through this process. We think that the number of frozen embryos in this country is northward of 500,000. 83% of frozen embryos are not for research, but for families, for fertility, for the growth of families. Alrighty. This is just a statistic on as you age, the live births that are resulted go from about 50% under the age of 35 up to less than 5% over the age of 42. This was the big deal when I was in Norfolk. How many embryos do you transfer with each cycle? Now, back in the 1980s and 90s when I was in Norfolk with the in vitro group, what happened was that there were many clinics in the area trying to catch up to our data. So I remember Howard Jones saying, we're only going to put back 4 embryos. To put back more than 4 is unethical because of the higher preterm labor rate. Because when you put more children in the uterus stretches and the uterus contracts against it, and so those children are delivered earlier. Right now in OBGYN, premature deliveries are a major national problem. One of the biggest reasons for that is because of this procedure. So once again, we were only putting back 4 because that was ethical, what we believed was ethical. There were centers in the country putting back 15, 17, 20 to get 1 child. So then when they were getting 6 and 7 and 5s and quints and quintuplets, what was the answer? The answer was, well, okay, first let's try to put back less and less. Better science, we can do it. We can make that loaf of bread a little bit better, a little bit more efficient, less hormones, less side effects. But now we put back between 2 and 3 on the average. That's what this chart does. Why? Do you think that when a woman puts back 3 embryos, this is a woman who's been infertile, the pain of infertility, and now we put back 3 to get 1. What is that all about? And then if you get all 3, then the docs will tell you, you know what, we might have to kill 1 in order to have the pregnancy be as healthy as we can get it. Unbelievable. And this is the pain and the suffering and the challenges of what we're seeing. This is some data on IVF and prematurity. I'm going to go through here. IVF and birth defects. So once again, infertility treated with abortion, schizophrenia of parenthood. This idea that imperfections through designer children, we can now do pre-implantation genetics. That is where we take 1 cell out of the embryo or the blastula on the right. The one on the left is actually what it looks like when it's implanting into you. We can take one of those cells and look at its genetics under the microscope and kind of begin to tell you what your chances of are having a genetically affected child. Remember, this is done before implantation. So on one end, they're trying to deny the humanity of that, but on the other end, they're using the data to try to predict what your child will have in the future. And then there's a whole area here we can get it maybe into the Q&A about exploitation. This idea of donor eggs and donor sperm. We now are having 100,000 women in this country are now undergoing donor egg in vitro fertilization. It's where we are paying women, healthy women, specifically specific types of women, large sums of money on the average of $2,000 to $7,000 a cycle to become super ovulated, to give them drugs for them to go from, rather than ovulating 1 to 2 eggs a day, to ovulate 10 to 50 eggs during a cycle. And then so those eggs can be harvested either for research or to be given to women who are older and whose eggs are no longer have the quality of being of conceiving. And so the last thing I'm going to kind of conclude on here is what we try to do at the Tepeyac Family and Divine Mercy Care. We fully believe that health is based on relationships, sacrificial relationships found in community. We want to walk with and accompany you. What does that mean? It means that when you look at people across the United States, that health is truly based on whether there is an intact family around the sick person. So if you have a 60-year-old man with hypertension and diabetes in 2 different locations, the one that has the intact family, those who care about him, will do better with morbidity and mortality than those who are given more services. It's not the amount of services that they're given, it's actually the care given, the love given. So health is actually based on sacrificial relationships found in community. For us, medicine is an act of mercy, like feeding the hungry, instructing the ignorant, housing the homeless. It's not a political football to be kicked around. We've learned to hate the disease, but love and respect the person. Meaning you don't get rid of the problem, the disease, by getting rid of the person with the problem. We'll talk about more of that in detail. And then in solidarity and in our community, we work together, we partner with people, whether it's partnering with our newfound friends at Hosea or what have you, but trying to work with pregnancy centers, trying to work with social agencies, trying to work with maternity homes, trying to work with emergency rooms, trying to work with other practices to help make abortion unwantable, children welcomed, families stronger, and communities healthier. We try to take these emphases of Pope Francis that this particular parish is trying to take, this idea of evangelization. The drive to share the good news of the gospel is fueled, as the title of his apostolic exhortation suggested, by the joy that believers find in their faith. The mission is to spread this truth and love, this idea that human life is sacred, made in the image and likeness, that mercy is a gift. At the Tepeyac Center, we try to be joyful in what we do because, once again, the Holy Father talks about how that lack of joy pushes people away. We want to be open to the Spirit, and we want to get to the margins, trying to serve those less fortunate than us, where it's messy. So the principles of divine mercy care is about service, seeing the underserved, because remember, we're trying to serve our community, our Northern Virginia area. We try to provide inspiration to the next generation of docs, whether it's medical students or nursing students or PA students or other practices that are having a hard time navigating through healthcare reform. The other piece is unity. We want to bring together the body of Christ, whether it's Catholic or non-Catholic, work across the border in regards to this idea of pro-life. And that lastly, mercy is crucial for compassion and touching the wounds of Christ. At the Tepeyac Family Center, this is once again, in the face of all this difficulty, this is how it happens at the center. We work with pregnancy center patients. Once again, the Tepeyac Family Center is a not-for-profit medical practice in Fairfax, Virginia. It's underneath Divine Mercy Care. It's a hybrid practice. Because once again, when I had my change of heart, and the Mother of God said, Johnny, in order to help my son renew the face of the earth, see the poor daily. Practice excellent medicine. And follow the teachings of my son's church as found in Scripture and tradition. She says, that's it. It's social justice and the gospel of life. It's both and. Have the conversation of conversion. When you talk to patients, find that question that I opened with is crucial for us. This idea of if you're going to go to IVF, because remember, oftentimes in today's day and age, it's not so much that I need to give them the answer, but I need to give them a question that makes them doubt, that makes me doubt. Because once again, that's only the place where the Holy Spirit begins to work. What can I do further? How far should I follow? So one is, we opened our doors at the Tepeyac Family Center to see pregnancy centers. We are a hybrid practice. We see patients with insurance, but we also see many people who don't, who are falling through the cracks. It's both and. It's a hybrid practice because we want to affect those who are suffering. We want to be able to touch the wounds of Christ. We have a mercy program where we try to find what can people pay and what can't they pay, and how can we provide these services. We do natural family planning and NAPRO technology. We do all of the NFP methods, from couple to ovulation method billings, to Family of the Americas, to Creighton, to Northwest Family. We use Tony Wexler's book a lot on taking charge of your fertility to those who have no religious foundation, but who are asking for more. They want more than just a contraceptive approach to life. This idea of the theology of the body, using the language, using the principles in our approach. A young woman comes to us from Winchester, Virginia. Says, I just got married, it's been 4 years, I'm not having good relations with my husband. And working up the history, I said, how many partners? She said, several thousand. I said, you were in the business. Yes, I was in the business, but now I'm trying to get back to a more healthy lifestyle, and I can't enjoy relations with my husband. We began to use the principles of the theology of the body, the principles of our faith. 9 months later, I got a little white note card that said, Dear Dr. John, thank you, thank you, thank you. For the first time in my life, I felt pure and healthy and not used, and I am deeply grateful. What happens is that we're trying to be a sign of contradiction in the Affordable Care Act, where the Affordable Care Act says all of these, abortion, contraception, sterilization, are all parts. Well, we're trying to say we are providing great reproductive care because we're providing also an alternative through natural family planning, this cooperative approach to the human body, where children are not sexually transmitted diseases and fertility is not a disease. So it should be cooperated with rather than suppressed. They're always welcome. There is a gradualness. Oftentimes we talk about you're a body, soul, and spirit put together. And so what happens is that it's a three-legged stool, body, soul, and spirit. And if you don't have one of those parts, your health is not optimal. You're an integrated human being. So are you taking your medicine? Are you exercising? Are you eating well? Are you working with that relationship, that one relationship in your life that's giving you a hard time? Are you working on it? Forgiveness, understanding. And then lastly, there is a higher power and you're not it. We say that because many of the people that come into our practice are fallen away somethings, falling away Christians, or they're nothing. It's gradualness. If I can't get them to prayer, you get them to meditate. The next year, they're going to come back and they're going to ask, why are you happy? I'm happy because I know Jesus Christ. Really? And you probably grew up, right? What? Catholic, Methodist, what? Go back to church. It's interesting. Each year they come back and it's a little bit more. It's a little bit more. It's cooperative. And so this idea of Caravaggio, poking your holes, poking your finger into the wounds of Christ. Infertility and reproduction and this desire to have a child or to have too many children or to have no children is a true it's truly a significant problem. And our church is very aware and very attentive. And they've given us the tools we need, scientifically as well as faithfully, to put the touch. That's what the Holy Father's talking about. This is what I mean by an epiphany. At our practice, fertility, fertilization, conception is that moment in the Sistine Chapel. How do you move people from one to the other? That's what we try to do on a daily basis. That's what this is what life is. Coming to know the power of the resurrected Jesus Christ. This idea of my body, my choice. When I was on one side of this, I could do whatever I want with it because God gave it to me and I'm the steward of it and I can do whatever I want. On the other hand, it's my body given up for you. Do this in remembrance of me. I'm trying to think about how do we create a Eucharistic medicine without scaring people away, but truly going to the heart of what it means to be human, that he is with us, that he is the divine physician, and how that person who's screaming on the one side of the slide, I understand her because that's me. That opening line of Mumford & Sons that I said to you, how woozy my eyes, I'm trying to understand your lies. That was me just before my conversion back to the faith. And then once again, it's transforming hearts through healthcare. It's both social justice and the gospel of life. That's the call of Matthew. He's the guy in the middle of the table pointing, dude, me? I say the same thing every day. Me? I was a history major, man. The question is how far to follow, and this is in conclusion. How far to follow? That's the line from one of the Cistercian monks in the movie of Gods and Men, the Algerian martyrs who got slaughtered in the mid-90s because they stayed with their community. Folks, what has happened in reproductive health over time, there was confusion at first when they changed the definition of when human life begins. And then there was the lack of discipline. The doctors who knew better didn't speak up. Some did, because I can only stand here today because I'm standing on the shoulders of many of you here in the audience. You NFP teaching couples who've been teaching for the last 30 years. John Kipley, Tom Hilgers, the Billings. My Lord, I stand on your shoulders. Those were the ones that were standing up in challenging times. First there was confusion, then there was lack of discipline, then there was division. Those who are pro-life, those who are pro-choice, right? We see that today. And now we're ending to a part where we're actually being persecuted. Martha Coakley, during her run in the Massachusetts Senate, talking about religious freedom. Yes, men and women who work in the emergency room do still have religious freedom, she was told. And then her response was, yes, that may be true, but they should not have gone into emergency medicine. They're now telling us that pro-life medical students should not go into OBGYN because of this issue. That's why I'm here. I would love to get into some questions and answers, because for all of us, it's how far to follow. How far do we go? These are the Jesuit martyrs of North America. But if I can find it here, I want to mention the names of De Quiros, De Segura, Gomez, Linares, Sabalos, the novices De Solis, Mendez, and Redondo. Those are the Jesuit martyrs of Virginia that gave their life in the winter of 1571. They died so we could do this. And so I just want you to know that I am grateful for this opportunity. I'm looking forward to seeing what Sister's going to come up with right after me here, because her books on the back have been well thought through, and we use them in our practice because they're so practical. The principles, the stories. Once again, I don't want to embarrass her, but when Francis de Sales could convert hundreds, if not thousands, he always used practical examples. I was so moved by what Sister Auer has written in that regard. Because just like the beginning of my talk was a brave new world, what does that word new mean? And for us, we rest in the joy and the love of Jesus Christ because he's the one that makes all things new. So thank you very much.
My husband and I have already benefited from your great clinic. So I have a very practical question. I'm wondering, with the new insurance and the new rules in healthcare, what do you see as some of the primary challenges to couples who do want to conceive and are running into kind of insurance issues over treating infertility as a disease?
You know how they said you won't know what's in it until you pass it, and then you won't know if it covers abortion until you buy it. Well, we're not going to know this answer for the next short period of time. What is good is that they've covered reproductive health, and they've talked about prevention, right? Preventive health is covered in every single plan. So that's encouraging. But certain states did a better job in covering natural family planning or the like. So In certain states, all reproductive health care is covered. And so that includes IVF, I believe. So that's a state like New York. So when you try to find the right diagnosis, because remember, once again, we want to cooperate with you. So it's A, you make the right diagnosis because they're covering diagnoses. We want to talk about prevention and health. And so there are states in the country where NFP has been covered a little bit better. But remember, natural family planning and cooperative medicine, NAPRO technology, have always had a hard time getting covered anyway, right? People, the big centers had to, the Paul VI Center needed some Knights of Columbus help to get through. It's very expensive. That's the part that breaks my heart about this, is that healthcare is so expensive. Here I am trying to help people have no room at the end, coming in, giving them care, and yet the reality is it's a very expensive process. So no, from a practical end, I think the NFP or the therapy, the surgery will be covered in its most, you might have to pay a higher deductible for it. The challenge is going to become on a kind of a ideological level. What's going to happen if we don't provide full reproductive services? So in our practice, we talk to patients about, these are all of your options. We're very clear. We're trying to be very upfront. We're not trying to go around. These are your options. We can't go with you here or there because I've done those, I've done abortions, and I can't go with you there. Now, you are always welcome to come back to us after you've had it. We will walk with you through it. We will send you to pregnancy centers. We will cooperate with the community, Mariah House, Assist, the list goes on, AAA, Front Royal Pregnant. We'll walk with you. We can't go there with certain of these things. And so from a practical point of view, it still should be covered. You're just probably going to pay a higher deductible, as many of us are. Okay. What else? Yes, ma'am.
Based on your clinical experience and any data, can you please speak to some of the medical conditions, psychosocial learning disabilities that children who are born of IVF experience, or if they do?
Yeah, it's interesting. You have to realize that the IVF world, it's all kind of self-reported. There's no oversight of the data. However, many different centers will report on their data. The big studies show that the major birth defect rate is about 4%, 4 out of 100 with IVF children. The big birth defect rate for this general population is around 1%, 2%. That's major defects. There are many minor defects. So in general, that's the data. Number two is there have been several studies looking at large collections of European data that show that there are certain conditions, either with tumors or with genetic anomalies, that are more prevalent in a small percentage. However, hemangiomas, which are a simple blood tumor, a benign blood blister, if any of us have a big red blotch that's raised and filled with blood, that's a hemangioma. It can be found in the liver, in the skin, in the hair. That's been shown to be increased. And yet the data is, I'm being very cautious because once again, I'm not going to throw stones at it. However, the psychological, one of it is the physical deformities. But what do you do as a mother when you've made 10 embryos and they only use 2 because they're trying to make it more gentle, and yet you have 8 that are frozen? Or some of the, like at our place, Georgiana used to clap when the embryo was made that was healthy, and there was silence when the embryo that was made that wasn't healthy. Do you know what that's like to take a mother who believes in unconditional love, who loves her children, who is trying to be a good mother, and she's going through the nth degree to get... the loss rate, the frozen embryo rate. So the psychological damage that I see are the women who come into me, and whenever they've gone to IVF and then come to Tepeyac, all you have to say is congratulations at that point, because the child's in front of you. The child's in front of you. But you begin to ask, was it hard to do? They all say yes, psychologically. They all say, I have 5 that are still frozen, Dr. John. What do I do? You know, I probably wouldn't have done it if I only knew. That's where it really becomes traumatic, that psychological challenge. And then the last point to your question is, I've had 2 patients now who were conceived down in Norfolk, who came to George Mason. So they're now 19 or 20 years of age. And they both at the end of their visit said, Dr. John, I think my mother wants to kill me. And, you know, this is a 20-year-old young lady. It's not, teenagers, I have 2 boys. It's not unusual for them to say certain things, but this was a little out of the ordinary. And I said, what do you mean? She goes, well, I just learned in my biology class about embryology and, you know, life and stuff. And my mom said that I was an in vitro baby. And they loved me so much that they went through all this expense. And I asked her, I said, well, do I have any siblings? And the mother says, no. And I asked, well, but did I have any, how many embryos did they have to get 20 years ago? Oh, 12. She goes, Johnny, I feel like, Dr. John, I feel like I'm on the Titanic. I'm a survivor of the Titanic. If I wasn't perfect, would my mother have loved me? Would she be willing to risk ending the lives of my sisters and brothers in order to get me? It makes me feel real creepy. And I'll always remember it. And another one came just a little while ago. Once again, it's not benign. Once again, this process helps many people have children, and people go on and are very happy, but that that fear, that deep-seated anxiety. Why are so many of us on antidepressants? This particular community, upwards of 60%. So, any other questions? Yes, ma'am.
What is the church's position on embryo adoption, and how are we going to address that as 500,000 chronologically frozen humans? How do we, as the body of Christ, show love to them?
That question I'm going to defer to the expert, Sister Teresa Auer. No, you know, this is the only time that I've known and read is when the church has said, we have been painted. You know, you read St. Thomas and he's got the answers, and you read his Summa and he's got a question and an answer, a question and an answer, a question and answer. And yet we've come to a place where there are no, on this particular issue of embryo adoption, I'm going to leave it to Sister, but what I am going to just preface it by saying is that the church has said we've come to a place where there's no great answer. Can you imagine? The Holy Spirit speaking through the church says there's no answer? Why is that? Initially, I was on the side of, listen, man, adopt them. There's children, they're in a burning building. We need to get them out of there. I don't care who put them in, I don't care where they are. I just want to go in. So snowflake adoptions, I encouraged. Johnny, by encouraging that, you encourage the system that made them. Oh, okay. So the church comes out in one of its most recent documents, Dignitas Personae, I think, and they said, we really shouldn't, you know, this is a situation that has no real answer. But it's a good question. We have seen many snowflake babies in our practice. Thank God. There was a, yes, sir, in the blue shirt.
Is there a link between abortion and breast cancer?
The answer to that is yes. I can't get into it a lot because I think of the time. If you want to talk offline, I can. But back in the 1960s, 1960, what 2 countries had the highest breast cancer rate in the world? Russia and Japan. Why was that? Because they've been aborting pregnancies there since the 1950s. They had the data. So back in the 60s, those were the 2 countries that had breast cancer rises, especially before the age of 50. Just to give you kind of a general overview, is that, once again, cooperating with the human body, as the breast begins to change during pregnancy, those high hormone rates turn the breast from a sweat gland into a milk-producing gland. Certain types of cells are made. When you interrupt those hormones by killing the fetus, the baby, those hormones drop and those cells are left in limbo. They can't go forward to be making milk, and they can't go back to the way they were, so they're kind of trapped. That's the mechanism, generally speaking, about how they become cancerous. And these are cancers that usually happen before the age of 50 in breast cancer, not the age-related. Remember, 1 in 9, 1 in 8 women by the age of 90 will have breast cancer if you live that long. So what happens is we've now looked at the data, and they've said over and over, no, there's no association. Well, sometimes there's no association because you threw out of your study group all those women who had the precursor to that cancer. So if you develop DCIS or carcinoma in situ, we'll just throw you out of the study. Why would that be? Number 2, let's stop the study, the California nurses study, 2006 or so. They stopped the study at 8 years follow-up. Why did they stop it at 8 years? Because by year 9, they were beginning to see cancers increase. And then lastly, Janice Darling at the National Cancer Institute, she did a big study and said, you know what, there's no association. However, in the subgroup of women under the age of, the women who had breast cancer in their family and the women who had an abortion before the age of 20, so they looked at like 1,400 women, but in that subgroup, there were 12 women. All 12 developed breast cancer before the age of 50. 12 out of 12 in that subgroup. And yet it wasn't even mentioned in the text of the report. So yes, there is an association. There is an increase of anywhere from 30 to 300%, depending on what studies you look at. Most of the epidemiological studies, and I'm 21 out of 23, I believe, have showed an association. But we're getting more and more politically correct. And once again, this is data, right? And we're driven by a world that accepts abortion and contraception as standards. So yes, sir. We can talk more about it. Yes, ma'am.
Hi. You talked about kind of the indoctrination that's going on in med school. And I'm an attorney, so I saw that in law school. And so I wanted to ask if there's anything that's going on to kind of push back against that and kind of say, hey, wait a second, I know this is what they're teaching, but it's really not exactly right.
So there have been really great people in right-to-life groups across the country trying to get into medical schools. But because of a certain thing on my resume, I used to do abortions and now I don't, it gets you a little bit more access to these audiences. We also figured out that you get to their stomach by doing it at lunchtime and providing pizza, and people come in droves. At the Mayo Clinic, we did it at the Catholic Church across the street. There were 70 students and 100 professors on this topic of, if abortion is so good, why don't more people do it? The answer to that is because of the damage done. When this hand was 7 or 8 inches away from a surgical abortion several times. That affects you. And so when I go give this talk, it's experiential, but it's factual. I'm trying to use phenomenology. I'm trying to use language to say that there is a subjective turn. You have a subjective right to your opinion, but there's also objective truth, right? And we're trying to bridge that gap. So Catholic Medical Association, medical students for life, they're now getting good, qualified people into those schools to give the talks or to give the lectures. And believe it or not, there are many schools in the country, whether it was at Harvard or whether it was at Chicago or whether it was at Southern Cal, they welcomed us. We disagreed, but the second piece is that We're just now getting to the point where there are residency programs because abortionists are becoming less and less, there's supposedly 1,700, that number's been stable across the country. They're now telling us, we don't want you here if you're pro-life. So when, once again, Harvard comes to mind. You have to sign a waiver. Emory University, you have to sign. Because they're very aggressive in teaching. McGee Women's in Pittsburgh. What happens is that we are going to start needing good law to help us defend our right to religious freedom, because once again, the specialty of OBGYN is becoming adverse to a pro-life mentality. So I think that's it. Okay, thank you so much.